All right. Welcome, everyone, for those who are here for compassionate overdose response, and also for those who were looking for a comfy chair in the air conditioning. Welcome as well. So this panel was put together by Alex Rask at the University of Maine, Carrie Barton at Portland Public Health, Lauren Hunt from Maine General Harm Reduction, and Mickey Rice at Maine Access Points. I am not Alexander Rask. Poor Alex was feeling fine a week ago, and now Alex tested positive for COVID. He is on the live stream. Hi, Alex. And so I'm pinch hitting for him. I'm Dr. Daniel Susi. I work with him at the University of Maine. And we all sort of work with each other on our various substance use disorder programs. So if those of you who are familiar with options, I do the data and evaluation for that. I'm the project director for the Maine Drug Data Hub, for those who are familiar with that. So that kind of who I am and why I'm up here, right? So today I'm going to provide some context about the Maine Naloxone Distribution Initiative program, and my co-panelists are going to talk about the work in the trenches around compassionate overdose. So they're going to do things like center naloxone policy discourse around compassionate overdose response, provide context around the overdose reversal drug landscape in the wake of the new kind of over-the-counter classification by the FDA. They're going to highlight that overdose is an oxygen emergency, right? And they're going to put at the center of the discussion that overdoses are traumatic for all of those involved, right? So they are traumatic for the person who overdoses, they are traumatic for affected others, and for those who respond to those overdoses. All right, so I'm going to provide you like a quick overview of what the Maine Naloxone Distribution Initiative is for those who are not familiar. So it stems directly from Executive Order 2 in 2019 that Governor Mills passed. And so in that executive order, it's really designed to implement immediate responses to Maine's overdose epidemic through like this multi-pronged approach. And so one of those provisions, and she mentioned it in her speech earlier, right, was to make naloxone more widely and readily available, affordable, and accessible. And so right now, through the Maine Naloxone Distribution Initiative, the Office of Behavioral Health kind of coordinates funding for the naloxone purchase, contracts with naloxone distributors, and then the priority population that has been identified through the executive order and through other state leadership, as well as working with harm reduction folks, is that the priority population since 2019 has been those that are at high risk of overdose and those with high needs. So those are folks that have barriers to purchase. So this can be organizations, right? So community organizations, public health organizations, harm reduction organizations, FQHCs, things like that. Or it can be kind of individuals through networks of end users, through things like options, SSPs, or even like the Attorney General's naloxone distribution program or the Maine EMS Leave Behind program, right? So the public health distribution of the Maine Naloxone Distribution Initiative really buttresses in a good way and builds upon the state's public safety and law enforcement distribution, which began, so the MNDI began in 2019, but all the way back in 2016 when Governor Mills was Attorney General, she started a law enforcement distribution program where law enforcement officers started carrying Narcan in case they responded to an overdose. And so since 2019, this program has grown tremendously. There's a website, media, there's a mobile app. Those who are interested in that, I have some wallet cards up front afterwards. The website is getmainenaloxone.org. Through the Options program, so Options, when that was being developed, they decided that the Maine Naloxone Distribution Initiative was the kind of venue to get naloxone to the Options program. So Options has actually distributed about 20,000 doses as of this July through Maine Naloxone Distribution Initiative, Naloxone. Maine EMS has distributed about 600 doses through the month of May. And right now our network has grown to over 580 active distributors and have it on handers. So this is probably 5, maybe 6 times the amount that we had initially during that during the first year. And so the Maine Naloxone Distribution Initiative is a tiered distribution system. So there's 4 Tier 1 distributors. So there's Bangor Public Health, Maine General, Portland Public Health, and Maine Access Points. So they are the organizations that kind of hold state contracts for distribution, and then they are responsible for onboarding and distributing to organizations that then become Tier 2 distributors. And they also distribute to individuals as well. Like I had said, there's over 580 active Tier 2s right now. They are onboarded through unique processes through each Tier 1, and they must follow the organization's protocols for naloxone distribution. They also have to collect data on distribution, on reversal data when it becomes available, if it becomes available, and then that is reported back to the Tier 1s. And so these Tier 2s are really have a varied distribution context, right? So there's different state programs I talked about, right? Like Options, but also there's clinical sites, there's public health, there's public safety, there's businesses, schools, libraries, harm reduction organizations, SSPs. So it really runs the gamut from a whole variety of contexts, right? And then our Tier 2s are broadly defined in 2 big categories. We have Category 1, which is redistributors, and then we have on the other side, have-it-on-handers. And so have-it-on-handers, right, that might be your school, your library, who has naloxone on hand in case there's an emergency, right, so they can respond. And so here's a map of the distribution network. So you can see that Bangor Public Health is in kind of the brown color, and they have like the northern, northeastern part of the state. So their catchment areas is about 5 counties. So Aroostook, Piscataquis, Penobscot, Hancock, and Washington. Maine General has kind of that center swath of the state with, in western Maine, right? So Somerset, Franklin, Oxford, Androscoggin, Kennebec, Waldo, Lincoln, Sagadahoc, and Knox. And then Portland Public Health has kind of like that urban Cumberland and York counties. Maine Access Points is unique as a Tier 1 because they have statewide distribution, mostly through a kind of advanced peer-to-peer network. So getting back to those Tier 2s, right? So like I said, we have those 2 big categories. We have have-it-on-handers and redistributors. So have-it-on-handers typically have naloxone in case there is an emergency, right? So as a safety measure. So these are places like schools, libraries, businesses. Typically, they have naloxone for personal and internal use, and they're unlikely to request refills, right, unless they kind of have an emergency on site, use their naloxone, and then they may reach out to their Tier 1 for a refill. The other category, which is probably where the bulk of distribution comes from, is from our redistributors, right? So these are folks who obtain naloxone to then distribute it into their their communities, right? So they're likely to ask for multiple refills, and these are really a variety of contexts. So clinical sites, harm reduction organizations, community organizations, recovery support agencies. I think there's even some jails, law enforcement officials, SSPs, Maine EMS, options, harm reduction organizations. So it really spreads throughout a lot of different contexts where people who use drugs have contact. And so here's kind of some impact of the Maine Naloxone distribution to date. So the public health side, so this is the side since 2019, right, has distributed about 500,000 doses of naloxone, received nearly 8,500 overdose reversals. The public safety side has about 20,000 doses distributed since 2019, with over 1,700 reversals reported. So combined, this is nearly 520,000 doses of Narcan into the community, with over 10,000 reversals, successful opioid overdose reversals reported. So the Maine Naloxone Distribution Initiative really is an integral part of Maine's opioid response strategy. So we have the options program, like I said, the Maine EMS Leave Behind program. Earlier today, there was discussions about increases in treatment, increases in recovery. So all of these things combined actually has played a role in Maine's reduction of overdoses. So from 2020, if you compare 2023 to 2022, Maine experienced a 16% reduction in fatal overdose. And then that trend is continuing in 2024. So according to the Maine Drug Data Hub, as of May, we're seeing nearly a 9.8% decrease in fatal overdoses in the first 5 months of 2024 in comparison to the first 5 months of 2023. So again, that trend is continuing downward. And it's really interesting as this program is maturing and has kind of reached maturity after 4 or 5 years. So I'm going to turn it over from here to Mickey, who is going to discuss the overdose reversal product landscape, and then from there, Carrie will take over and discuss the rest of the presentation. Thanks.
Can everybody hear me okay? Awesome. All right, so I'm going to go over a little bit of what the product landscape looks like right now with naloxone. So first, what does the Maine Naloxone Distribution Initiative provide? We have 2 formulations that we provide. We do the standard normative dose of nasal naloxone, which in the past has been 4 milligrams, and we also offer the 0.4 milligram intramuscular. So there are plenty of products outside of what we offer at the MNDI. So as you probably know, over-the-counter nasal naloxone has been approved within the last year. And so that's really changed a little bit of the landscape with people being able to get it at the pharmacy. Another thing with new naloxone products and naloxone non-naloxone products is that we've seen a flood in the market for high-dose naloxone or like longer-lasting non-naloxone products. We've also seen the, can't think of the word. We've also seen low-dose naloxone become available recently, and we'll go over that in another slide. All right, so some of the brands and types available is, so the intramuscular naloxone, it's the generic naloxone hydrochloride. It's what's been wanted by people who use drugs and harm reduction organizations for a long time, and it's something that people who use drugs are used to. We also have Narcan, which is the 4 milligram intranasal. we've seen the introduction of Cloxato, which is an 8 milligram intranasal, and was marketed to combat high potency fentanyl in the supply. And then you have Revive, which was just approved within the past 6 months for over-the-counter use. It was the second nasal naloxone to be approved for over-the-counter use. Like I said, it's a 3 milligram intranasal. And then there's Zimhi, which is an intramuscular, but it's a 5 milligram pre-filled intramuscular. And so to put that into context, for intramuscular, you can get 0.4 milligram, 1 milligram, or 2 milligram, or the pre-filled 5 milligram. We haven't seen any evidence or reason, like actual evidence for the higher dose naloxone, but they are there. And then Opvi is a non-naloxone product. It's actually nalmefene, and it binds the opioid receptors. Like, it has a stronger affinity to the opioid receptors and will stay longer. So it has a higher risk of causing precipitated withdrawals, and those precipitated withdrawals could last quite a while with Opvi. So some complications of the mixed product landscape. Historic and normative naloxone products, such as what we distribute at the MNDI, are a known quantity. They've been proven effective. Harm reduction and clinical best practices have really stabilized around these doses. And safer use education for people who use drugs is always going to be more effective when you have a continuity of the product that you're offering. Novel products that haven't been tested on humans or don't have, not humans, but haven't been tested on the general population of people who use drugs or don't have input from people who use drugs. They market the stuff so that it is higher dose and supposedly works better for high potency fentanyl, but we haven't seen any evidence to actually show that. What we do know is that people who use drugs that are given high dose naloxone, they have a higher chance of severe withdrawal, which can also lead to pulmonary edema and tachycardia on its own. All right, so some risks of high dose naloxone. As I said, high dose naloxone has really been marketed for high potency fentanyl, even though we don't have the evidence to back it up. What does differ, like I said, is the severe withdrawals, the length that somebody might be dealing with withdrawals, and other risks. And so I just want to make sure. All right. And so what's been proven to work is combining oxygenation with naloxone, especially with the drug landscape nowadays. And so, that's clinical best practice and harm reduction best practice. And the higher dose naloxone can also cause people to go out and use while they're waiting for it to wear off, which can be dangerous because then once the naloxone wears off, they could re-overdose. So this is Revive. Revive is a 3 milligram nasal naloxone. Like I said, it was just approved, I think, in January for over-the-counter use. So the manufacturers of Revive are a nonprofit pharmaceutical company whose mission is to bring low cost and no cost naloxone to communities most in need. They're the only naloxone product that was manufactured with input from harm reduction programs and people who use drugs. And the manufacturers of Revive have also agreed to give 10% of their first year's production to harm reduction organizations and other organizations that are like underserved, unserved. So they've pledged to give 10% of that to harm reduction programs for free. All right. Hold on just a second. All right, and the only other thing that I want to say about Revive is I hear a lot of pushback of like, well, we're having to use more doses because people are using higher potency drugs. And the evidence actually shows that the dosing needed for those higher potency drugs hasn't changed much across the years. And so Revive is 3 milligrams instead of 4 milligrams, but it's still a lot stronger as is than the 0.4 milligram IM that is sought, that's most popular amongst drug users. So overdose as an oxygen emergency. All right. So during the COVID-19 pandemic, aversion to rescue breathing, we really saw aversion to rescue breathing because people didn't want to catch COVID. But we really need to return to rescue breathing as being one of the most important things you can do during an overdose. Prior to naloxone, that's what harm reduction organizations and community members did. They breathed for the person until they could breathe for themselves. Yeah, and this just talks about, harm reduction education should be tailored to include rescue breathing and to say how important it is versus paying attention to wakefulness, especially with the polysubstance, in the polysubstance context, like with new cuts like xylazine and benzos being in the fentanyl. There's an increased need for rescue breathing and naloxone in combination. Because the naloxone is not going to work on opioids. And because of the time that it takes for naloxone to kick in, the 2 to 3 minutes, that could be the difference between someone, being brain dead or having brain damage or not throughout the overdose. What does an oxygen-informed response look like? So, first of all, it looks like dosing naloxone at the minimum effective dose and titrating up if need be. Performing rescue breathing, performing breathing assessments in between doses to really tell you if the naloxone is working or not instead of focusing on wakefulness. And just the understanding that the person using drugs, the first responders, bystanders, we don't actually know what's in the supply. And so best practice with not knowing exactly if the naloxone is going to work because what's in the supply is to do a combination of naloxone and rescue breathing. And you can breathe for somebody until help arrives or until they come back. So what are other states doing? So in SSPs, harm reduction organizations, clinical care settings, emergency rooms, one of the things is supplying low barrier masks with the naloxone, so people might feel a little bit more comfortable doing rescue breathing. Pulse oximeters are great to have while you're responding to an overdose because they tell you the oxygen saturation in the blood, and they'll also let you know what the person's heartbeat is. And then oxygen itself, especially in like SSPs and emergency rooms, like the little cans of oxygen, is you see it a lot in like overdose prevention centers and ERs. And then, as I said, including breathing assessment instructions with your overdose education. And so I am going to pass it along to Carrie.
Can I interrupt for 2 seconds?
Yeah.
Somebody's lost a cell phone in here in the last breakout session, so as we're leaving, if you wouldn't mind checking your seat stuff. It's in a teal case, back towards this here. Towards the front, fourth row-ish. So if you see it on the way out, that'd be awesome. Thank you.
All right. How many of you have had a Narcan training before? And how many of you would say that the training was done in a trauma-informed way, done by a harm reductionist? A little bit less, okay. So I want to point out this quote from Eliza Wheeler from Remedy Alliance, who is definitely a proponent of low dose and compassionate overdose response. I'm not going to read through everything here, but just know that a lot of the principles that we're talking about today are embodied in this quote. So we must remember that every single overdose, we hear a lot about the number of overdoses. I think over 3,400 overdoses have been documented so far in 2024. Of course, that's only the number of overdoses where 911 was called. There's many other community overdose reversals that may occur, potentially because that individual did not feel comfortable calling 911 for fear of what was going to happen when first responders or police arrive on scene. So we have to remember that every single overdose, every number that we're talking about is a human. It's a human interaction. Yes, it is a medical emergency, and yes, there are medical interventions, but remember that every single overdose event is a traumatic event for that individual. Reducing harm, we're talking about harm reduction, goes beyond simply reversing an overdose, but supporting that person through that overdose experience and not compounding the harm. We'll talk about some examples of that later. When someone is coming out of an overdose, they may experience panic or fear, in particular if there's, ambulance there and sirens and police. There's a lot that could potentially be going on at that scene. Also, confusion or delirium based on going through this traumatic medical event. Pain or discomfort, especially depending on what they took and which overdose reversal agent was given to them. So, what we just heard from Mickey about those high-dose naloxone products, that's going to put someone into pretty severe withdrawal. The key with overdose reversal is to give someone enough naloxone to reverse that overdose, but not too much as to put them in unnecessary withdrawal. They're just going to feel worse the more you give them. And, also recognizing the continued effects of other intoxicants and what they may have taken. Mickey did mention, xylazine. So again, what we're looking for in overdose reversal is restoration of breathing. So that's why we're focusing on overdoses as an oxygen emergency. We're not necessarily looking for the individual to wake up. And these can be pretty traumatic experiences, right? Because you just want the person to be conscious and wake up. But unfortunately, with the really unsafe drug supply we have, a lot of folks don't know what they're taking. There are many other compounds that can increase sedation beyond just fentanyl. So what we're proposing here today is to establish a standard of care framework for compassionate overdose response. So beyond just a Narcan training and calling 911. And these are decades-long experiences, and those developed by those with lived experience, people who use drugs, harm reductionists who have been doing this work for decades. If someone has a negative experience with an overdose, that is going to impact how they may respond to a future overdose, and also, how the future for them and that individual. So for example, if there was a situation where someone was given way too much naloxone and they're incredibly sick, why would they necessarily want to go to the hospital? A lot of people who use drugs may experience stigma in healthcare settings, and they didn't need to receive that much naloxone, right? So this is why it's so important to do this community-wide training, so individuals know exactly what to do at the scene of an overdose. And when people who use drugs are treated with dignity and respect that they deserve, that is going to increase likelihood that they'll engage in harm reduction and engage with treatment and things like that. So we have to be mindful of every setting, right? So when we're responding to an overdose, it's really important to recognize the situation that you're responding to. So when you're coming up on someone and maybe they're alone, like you're a bystander responding to an overdose and the individual is alone, and we responded to the overdose, it's really important that we don't leave that individual alone after that. So even if they decide, I'm not going to do hospital transport, that's fine, we have to respect that, but also make sure they're not left alone. So stay with them, call a peer, friend, family member. That person is at risk of a second overdose once the naloxone wears off, so we don't want the individual to be left alone. We also have to recognize that every single overdose looks different. So I can tell you from experiences and overdoses that I've responded to, there is not one that I can say is the same as another one. It totally depends on the person, what they took, and what, how much naloxone was given, if rescue breathing was administered, that sort of thing. And also recognizing that every single overdose is going to look different, even based on geography, right? So depending on how much naloxone or training is in that area. Luckily, we have the Maine Naloxone Distribution Initiative to increase that, but even like EMS response time, right? So that's going to be different in City of Portland versus, Bridgeton or Rumford, for example. So let's talk a little bit more about assessing breathing and overdose as an oxygen emergency. So we're definitely bringing rescue breathing to the forefront of this conversation when we're responding to an overdose. So yes, give the naloxone, but then rescue breaths. Evidence shows that people can, as Mickey already mentioned, evidence shows that people can wake from an overdose by oxygen alone, and naloxone will help, speed that process up. But for individuals, especially who have taken something that may have additional intoxicants in the drug supply, it's really important that we give that person rescue breaths. So like I mentioned in the start of this, we want to give someone the minimum dose of naloxone available. So that if you have that 3 milligram Revive, that's awesome. But also if you're trained in like intramuscular naloxone, that is also going to decrease withdrawal symptoms for that person. Most commonly in community-based settings, and what we're commonly distributing through the MNDI, is that 4 milligram Narcan dose. So if you have that, administer it, wait 2 to 3 minutes, and give another dose if needed. Of course, giving rescue breaths in between. What we're looking for is the individual to restore breathing. So for the chest rising and falling, for the color to come back in their face, we're not looking for the person necessarily to wake up. That doesn't happen all of the time, especially with the very unsafe drug supply. So this is just a summary slide kind of talking about the aftercare. So after someone has experienced an overdose, again, being mindful of the environment. We don't want to leave that individual alone. Also recognizing, like, if you're responding to an individual in a very traumatic situation, such as an encampment, for example, that individual may have everything that they own right there with them. So if they don't want to leave, they don't want to go to the hospital, we're not going to shame them for that, right? That is their choice and their autonomy to decide. We also, again, don't want to ever shame someone for their substance use in that moment, and we don't want to increase panic. So one thing I always recommend, if you're at the scene of an overdose and there are multiple people who can respond, you can take charge and say, administer naloxone, point to people so that people have like specific tasks. So one person could administer naloxone, someone else is calling 911, someone else is giving rescue breaths. And then there could also be rotation so as to reduce trauma for a single individual responding. And then at the, as the person is coming back into consciousness, if that does happen for the individual, that would be a time to talk with them about, getting into harm reduction program. If they're not connected with the syringe service program, we have hundreds of folks that we work with per week, and these individuals are supported by a lot of syringe service providers across the state, keeping people safe and getting them connected to the care that they need. And with that, I'm going to open it up for questions. We have a couple of microphones here. I can run out. Or maybe Dan.
There's a thought among some, thank you for this. There's a thought among some in law enforcement that naloxone is not going to work when xylazine is present. Can you address that myth?
Yeah, thanks for that question. So anytime it looks like an overdose, we want to administer naloxone. So if the person is not responsive, definitely give them naloxone. We're commonly, yes, you're right, naloxone is meant as an opioid overdose antagonist, so it's not going to reverse the sedation due to xylazine, but we commonly see fentanyl cut with xylazine. So when you administer naloxone to someone who has both fentanyl and xylazine in their system, it will reverse the overdose due to the opioid, due to the fentanyl, but then the individual may stay sedated because of the xylazine. But you save their life by giving them naloxone because they're restoring their breathing. So that's why we're focusing on this in this training.
Another myth I was hoping you might address, I feel like we even heard it in the main room this morning, there's this idea that even just a someone who might be a bystander responding with Narcan has that fear in them sometimes. I'm wondering if you could give some advice on just how to talk people through that. And, you know, to some extent, I know that a small amount of fentanyl can be harmful to someone. Like, where is, like, the line of, like, how careful they should be, especially if you know, like, rescue breaths and things like that?
Sure, yeah, I heard that came up at a session earlier. I wasn't at the session. Yeah, we do get this question quite a bit in trainings, and others, please weigh in. So essentially, the only way that you can experience an overdose on fentanyl is to get it in your bloodstream. So if you're just touching something, it can't go through the skin, right? So the skin is the largest organ we have in our body. Fentanyl cannot get through that. Also, if you're responding to someone, you know, say giving them mouth-to-mouth resuscitation, they're not going to have like drugs. People are not necessarily like eating their drugs, right? So you're not going to have drugs all over their face. Even if they swallowed a pill, there's not going to be like excessive powder all over their face. So we don't have to worry about that. You know, responding to overdoses myself, I have never had any kind of experience even close to resembling an overdose because of exposure. Does anyone else want to weigh in?
I think part of that piece of it is an adrenaline rush, right? It's a scary emergency situation. So that adrenaline rush can feel like you're losing your breath. And in those instincts, you might think, oh my God, I'm overdosing too. When in reality, it's just that panic feeling. Yeah.
Isn't the lethal dose of fentanyl like 2 milligrams or something? I mean, it could be depending on the person, but so even the amount, you know, that if it was present, I don't.
Yeah, it does depend on the person because everyone has a different tolerance. Yeah, it totally depends on the person, their tolerance. But ultimately, even if there were a teeny tiny minuscule amount, you know, you have to get it into your bloodstream to experience an overdose.
So if somebody, you know, happened to bite their tongue while they were bleeding, like does that complicate things a bit? Or I mean, obviously you're still gonna want to save the person. You're gonna give them breaths, right? But
Yes. Yeah, and the other thing,
bloodstream to them.
right. I think the other thing I want to mention is that I think like in the media and movies, there's this depiction of like copious amounts of powder everywhere, and that is not the case, right? So like a single shot is just, you know, a little baggie that, you know, it's just teeny. So we're not really worried about copious amounts of powder that you're like walking into environment and breathing this stuff in. So,
I was thinking more like if they had blood.
Yep.
In their mouth from,
and then they're
and
giving,
then you're giving them rescue breaths, right? So they bit their tongue as they were, I don't know, people bite their tongues, right?
yeah, again, like we're not worried about that person having the substance in their mouth at that point in time. Yeah. Yeah.
Do we have a sense of, like, where that myth comes from? Is it just
Yes.
information, or
YouTube. Social media, you know, these things go wild, as we know, on social media. Like there's some YouTube videos, I think even like a decade ago, this stuff started. And it was, you know, law enforcement personnel who was responding to an overdose, and there was like a body cam footage of them passing out. Could have been an adrenaline situation.
Yeah, and that's what's been, like, when people have looked at the law enforcement recollections, like, it's usually carried in local newspapers, and local news, and, yeah, it's been shown that a lot of the time it is a panic attack that they are experiencing.
there's not a lot of fact checking in those local newspapers always?
Yeah.
Thank you.
Yeah.
Are there any reports of people using fentanyl transdermal patches and they're overdosing and then they discover there's a transdermal patch on them?
Yeah, thanks for bringing that up. So what we're talking about today is illicit fentanyl, which is in the form of powder. So the pharmaceutical version of fentanyl is in the form of a patch, a transdermal patch, as you're describing, or a lozenge. So that is pharmaceutical grade, and that is a very different dose and administered in like a medical setting. What we're talking about today is the illicit powder version of fentanyl.
But if someone
Yep.
acquired those patches, you can put several on. You could do an overdose with them, sir.
Technically you could, but the reason why the street supply is so, unsafe is because people don't know the amount of certain drugs that are in there, like fentanyl and xylazine. And with the patches, yes, somebody can overdose, but it's a risk reduction technique right there, knowing what dose you're taking. So it is possible for somebody to overdose, but people are athlete to know exactly how much they're putting in their body if it's a transdermal patch.
So it's unlikely.
That's long acting, right? Like my dad was on it.
Yeah.
He had like, he got shit on his stuff, but like it would really like alter depending on what time he was on the 3-day. Like he was a completely different person. My mom could tell when it was starting to come up. It was like with personality changes, like they really had a really hard time finding out like when you're gonna start to overdose. Like he'd be waiting to kind of figure out what they
But yeah, technically it is possible, and the MNDI, we do these Narcan trainings in healthcare clinics as well, pain management clinics. Really, anybody's at risk of an overdose. Yep.
So my question is, if I work at a methadone clinic, and what does naloxone do? We know not to put somebody on Suboxone right after this naloxone. It's the problem of naloxone in the Suboxone to go from methadone to that. What is precipitated withdrawals like for somebody that is? Because I mean, I don't like to say it, but we do have some people that do fentanyl with methadone, like anything else. So what happens administering Narcan to somebody that's on methadone and fentanyl?
Does anybody on the panel want to take that?
So I actually used to go to a methadone clinic, and so precipitated withdrawals, I mean, it's gonna look like what normal withdrawals look like from methadone. I would probably say if somebody's doing methadone and gets treated with Narcan, they're probably gonna have some sort of precipitated withdrawals. You know, it can be vomiting, seizures, headache, sweating, cold sweats, you know, dehydration. Well, feeling like you're dehydrated, but yeah, pretty much the normal withdrawal symptoms, but it brings you from like 0 to 100 like that, rather than like slowly building up to the worst of the withdrawal. But naloxone only stays on the receptors from anywhere from 45 to 90 minutes, so it's not going to be pleasant, but if it wears off pretty fast, faster than Suboxone normally does.
So they could dose the next day for methadone after
Oh, yeah.
having naloxone the day before.
Yeah.
Yeah, that's, thank you.
Any other questions? Okay, well, thank you all so much for your time. We do have cards here if you're interested in learning more about where to get naloxone, and we'll stick around for other questions. But thank you so much for your time, and drive safe.